I thank you very much, Rick. And I also appreciate your willingness, everybody's willingness to let me go out of turn. But this is so clearly, I'm talking about the same thing that Don is talking about, and I think that it was, it would be good. Actually, it's the confluence of more rheumatology because not rheumatology because I've sort of given up on rheumatologists. I have not met a rheumatologist who's helped me in any of these patients at this point. But the point is really a genetic issue, and I'm really going to work hard to try to convince Allison that this is something we have to work on together. I don't have any conflicts of interest, although when I gave a talk at one of the international meetings, somebody got up and said, "But you're at the Chiari Institute. Isn't that a conflict of interest?" I said, "But that's, that's what I am." Anyway, it was a very weird time. And I need somebody to help me make a Venn diagram. Because I can't, I tried and tried and tried and tried, and I couldn't do that. The Sarah syndrome was I first recognized in a patient, obviously called Sarah, with no age, and she was absolutely devastated. She had an IV port, so that she could give herself before she got out of bed. She had to give herself IV fluids because if she started to get out of bed, she'd faint, and it was the dysautonomia in her was just tremendously awful. And so we've identified 23 patients in the last few years, and I have to say to Don that this is really premature for me to discuss it. It's something that's just beginning for me to think about, and I've gotten not nearly as far as I want to have gotten, and that's primarily the fault of the IRB. But so these are patients with 5 things, and they're a little bit different in their symptoms, but they all have these 5 characteristics. They have a Chiari malformation, although it's, as stated, and I'm very happy that we've had these two talks. Dr. Millerot, when he was talking about connective tissue disorders, he said that they weren't really Chiaris, they were LLTs, low-lying tonsils. So they were below the foramen magnum. There was crowding of the foramen magnum, but they didn't meet the criteria, the radiographic criteria for a Chiari. And the biggest problem in our lives is the fact that the neuroradiologists don't come to these meetings, and that we can't get neuroradiology to buy into the concepts that we need. Are you a neuroradiologist? Thank you so much for coming. I will kneel at your feet. So they had. And I have been trying very hard to get them to the table. But so they had a Chiari malformation or low-lying tonsils, and they have craniocervical instability, which we talked about in the last colloquium. And they all have Ehlers-Danlos syndrome, the hypermobile form, or one of the complex forms of Ehlers-Danlos syndrome. They all have severe dysautonomia, which in some ways is the most disabling part of their of what they have, and they have a pervasive pain syndrome, and there's so much argument about the term fibromyalgia that I think we have to find another term for it, but they hurt everywhere. They hurt above and below the waist and on the right and left side. So Ehlers-Danlos syndrome is a genetic condition that doesn't have biomarkers. At least the hypermobile form doesn't. Not yet, unless Allison's going to tell us that she's found one yet. But it's very interesting because in Ehlers-Danlos syndrome, I mean, some people benefit from, in fact, all of the Rakettes must have it. If you can put your knee to your nose, you've got to have Ehlers-Danlos syndrome, I think. And God didn't want anybody to do this. But in some people, it's really a bad thing. They have multiple dislocations, multiple surgeries, and they have a likelihood of having craniocervical instability. There's no biomarker. It's a clinical diagnosis based on the Baton or Beighton score, and it's very, very common. but the overall incidence is unknown. So let's look at what holds the spine together. That we know about the alar ligaments, the cruciate ligament, the tectorial membrane, all these things in front that hold the skull on, but there's also the posterior atlanto-occipital ligament posteriorly. And while this is a very strong stabilizer of the relationship of the skull to the spine, there is some role for the posterior atlanto-occipital ligament. And the problem is that when you do a Chiari decompression, you have to take the posterior atlanto-occipital ligament off, and it does not go back on. So you've created an increased stress, as Fraser has told us, a marked increased stress on these ligaments. And if they're stretched and weak from the beginning, you're going to make things worse. And that's the story of for the most part, of the Chiari Institute. A very high percentage of our cases are patients who have had a Chiari decompression, have worsened, and when the neurosurgeons and neuroradiologists look at their postoperative imaging, it looks good to them because there's flow dorsally around the cerebellum, but the big spike that's in the middle of the brainstem is ignored. So this is one of my favorite things that we got to get rid of that name. If we could only get rid of the name, we'd be all set. This article by Tom, which is ignored by almost everyone, it's a shame because it's a beautifully written, very carefully, and Paolo and Roger deserve a lot of credit for this too. It's a very crafted, thoughtful article that says a great deal, and unfortunately it's laughed off way too often. Of the 2,815 patients that they saw in a 5-year period, 12.5% had connective tissue disorders as measured by the Baton score of 4 or more. 1/3 of those 357 patients had failed, came to the Chiari Institute because they failed standard surgery for Chiari I, and 45% of the Chiari patients seen at the Chiari Institute had come after failure of the first surgery. So it's essentially a redo situation. So I'm going to talk a little bit about, we've now talked about the Chiari, we now talked about the craniovertebral instability briefly, which we spent a whole day on last time. And now we're going to talk about the other parts of the Serra syndrome. A syndrome, it's interesting, the name hangs on for decades or centuries beyond its useful time. A syndrome is a constellation of things that occur together. And we eventually will find the link. But until we find the link, we'll have to call them syndromes. And the thing that's most compelling is the craniofacial syndromes. We now have a clear knowledge of a lot of the genetics of these Cruzans and Aperts and Pfeiffers, and we know where the points of abnormalities are on this. But they're still calling them Pfeiffers. They still want to know, is it Pfeiffers or is it Cruzans? It doesn't matter. It matters what the genetics are. So the pervasive pain syndrome, and I think that for the purpose of, if I can convince you all that this is something worth studying, I would want that to be PPS rather than fibromyalgia, because the concept of fibromyalgia is so controversial. It is linked in a very negative way with the concept of Chiari, and I think we really need to have some thought about it. But everybody's heard of fibromyalgia, so when you start talking to the patients about the fact that they have a lot of these things, they have chronic they're tired all the time. So in children, and correct me if I'm wrong, because this is new, really fairly new to me. In children, and at least in Philadelphia, they call this AMPS, augmented musculoskeletal pain syndrome. As far as I can tell, it's exactly the same thing, except that people are under 18. And the neuroscientists who are studying it call it the central sensitization syndrome for the reasons that Dr. Long talked about just before me. It's controversial. There's no readily available biomarker for it. It occurs mostly in young women, and it tends to be passed off as not important to most physicians. Research studies, however, have found some positive tests that tend to make you believe that it's real, not just whining. In some of the studies, CSF cytokines have found to be increased, and PET scan and functional MRI, when you actually have a painful stimulus, they show widespread activity in the brain, as we've just heard. So it's real, and it's devastating. So our patients, this is what they have relative to the fibromyalgia or PPS. They have chronic pain syndrome with predilection for the cervical spine. They all have neck pain. They all have headaches. They have chronic fatigue. They almost all complain of a problem with short-term memory, and whether that's a biologic thing or a problem with just in chronic pain, I don't know. But they're most troubled by brain fog. They have trouble concentrating. They're not functional in their work environments, and they're depressed, as everybody would be, I think. The dysautonomia POTS stands for postural orthostatic tachycardia syndrome, and the discussion when this was first discussed in the literature would say that these are patients who don't drop their blood pressure but do increase their pulse to vary. But it's come to mean the postural changes in pulse and blood pressure. And most of these patients have fainting spells, they have lightheadedness, but they also have irritable bowel syndrome, detrusor and sphincter dyssynergy. They have dysfunction of sweating and abnormalities of temperature control. When you talk to them in the context of their families, they'll all tell you that when they're hot, everybody else is cold, and when they're cold, everybody else is hot. So there are some other things that I've found that go along with this. There's some patients who have been shown to have mast cell dysfunction. They're very sensitive to tape. You're trying to use tape on these patients postoperatively, they'll all yell at you. And the markers of inflammation, while are not dramatically increased, are at least high normal and usually slightly elevated. So Kevin Tracy is the director of the Feinstein Institute, which is the research arm of the North Shore LIJ system. And he was a neurosurgeon who gave up neurosurgery to study the role of the central nervous system in the control of the immune system. And every time I listen to him, I find new information about the effect of the brain on the autonomic nervous system and on the immune system, and they're all so closely interrelated that this is where the rubber meets the road for us. So what's going on with our patients? It seems to be, it has to be a dominant transmission. There are 3 males in this 23 patient group. It seems to have near complete penetrance because multiple female children in the same family will have it. There are, as I said, there are some males. It's an inflammatory condition, and that's the problem. It's seen by rheumatology who don't recognize it and they have a limited number of things that they can do, and none of them seem to work with our patients. There's an abnormalities of the central nervous system and central sensitization, which is what what fibromyalgia is supposed to be. What's really interesting is if you look at this diagram that's in one of Tracy's review articles, you see that everything sort of comes together right here, and that's really at the pontomedullary junction or the medulla itself anteriorly, and all of these things that are occurring, which include cytokine release and include the immune system, are in this one area of the lower brain stem. So this is where 9 and 10 come out, and that'll come into play a little bit later. So we now have a condition with these patients who have low-lying tonsils, or this one has a real Chiari. It was about 7 millimeters below, but still not. There are a lot of people who would not be very impressed with that because it's not all the way down to here. I don't think the depth of the tonsillar descent makes any difference at all, but it's the distortion of the anterior brainstem that I think is the most important part of all of this. And as you all have seen these slides again and again and again, this is unstable. If you extend and distract them, you can take the pressure off of the anterior brainstem without a transoral surgery. So this is the operation that we do for these patients. We decompress posteriorly and extend and distract them, and we can take the pressure off. So what have we, this is so early, and we have identified 23 patients with, actually it's 20 and 3 rather than 21 and 2, sorry. We've identified 23 patients with this, and they've all undergone intraoperative reduction and fusion of the anterior compression of the brainstem. They ranged in age from 4 to 28. There were no operative complications. There have been some problems with instrumentation. I'm sorry to say that we've not gotten any further than this, so I'm not going to complain, but I hate the IRB. They're not arguing with me about things that protect patients, but whether I'm going to be able to do the statistics right. It just drives me absolutely crazy. Based on early postoperative results, no patient has been completely cured of Sarah syndrome, but they've been dramatically improved. Sarah no longer has her port. She can walk around. She's now married. She was able to walk down the aisle with her new husband. POTS has dramatically improved in a few, and the quality of life has improved in all of them. But we need to go back and talk to them, and in order to do that, we have to get IRB approval. So we need to, this is what needs to be done. We need to identify the signs and symptoms that define the Sarah syndrome. I tried to do that for you today, and I'd love to hear a conversation about it. We have IRB approval to send CSF and serum to Akron for mass spectrometer to do metabolomics on this. I really, I'm so glad Allison is here because I really wanted to talk to her about this, because I think there must be a link, a genetic link for all 23 of these patients. And I can't go into long detail about the work that Kevin Tracy's done, but the work would tell me that all of this is mediated through the pathways within the brain that end up in the vagal nerve. And I think that there are, vagal nerve stimulation is FDA approved for epilepsy and shown effective for depression and obesity, and it's being studied for rheumatoid arthritis and for irritable bowel syndrome. So I think that the question that was brought up, is there an answer? I don't know whether there is or not. But I think that the idea of use of these patients, if they still have these cerebral symptoms, and there is no definitive neurosurgical treatment for them, I think we should consider vagal nerve stimulation, and I would like everybody to give some serious thought to whether we should try to do a study. It would take an awful lot of energy because these devices are quite expensive. But I really am excited about the the possibility that we could make a big difference in their lives with vagal nerve stimulation. Thank you.